Okay, let's dive right into this explainer and completely break down the urologic system. We're focusing strictly on the 10 absolute highest yield points you need to know to crush your nursing exams. If you're prepping for the ATI or the NCLEX, you already know how heavily renal and urologic questions are tested, right? Well, our goal today is to make this comprehensive explainer your ultimate study tool. We aren't just going to sit here and memorize facts, we're going to dig into the why behind them so you can walk in and confidently tackle any clinical judgment scenario they throw your way.
To do that efficiently, we'll follow this quick agenda. 1. Anatomy and physiology basics. 2. Assessing urologic system health. 3. Diagnostic and lab tests. 4. Key nursing interventions. And finally 5. Essential urologic medications. Let's get to it.
Starting off with Section 1, Anatomy and Physiology Basics. We really need to nail down the baseline before we can start recognizing the pathology.
And this image here brilliantly illustrates our macro to micro view. Over on the left, you've got the whole system's layout. You know, the kidneys tucked just below that 12th rib, the ureters, the bladder, and the urethra. But shift your focus to the right, because that is where the real action happens. That's the nephron. You actually have over 1 million of these little guys in each kidney, and it's a functional unit where the literal magic of filtration, reabsorption, and secretion takes place.
So, urine production itself basically boils down to 3 essential consecutive steps. First up is glomerular filtration. Think of this as a giant ultrafiltration process in the glomerular capsule, where water and electrolytes just get pushed right out of the blood. Second, we have tubular reabsorption. This is where your body actively pulls back the water, sodium, and electrolytes it desperately needs to maintain balance. And third is tubular secretion. That's the targeted dumping of ions like potassium and hydrogen straight into the tubules to keep your body's acid-base balance and serum potassium levels perfectly in check.
All right, here is your very first NCLEX key point, so listen up. You absolutely must remember that the kidneys do way more than just make urine. Sure, they eliminate metabolic waste, but they're also a vital hormonal powerhouse. For example, they secrete erythropoietin to stimulate red blood cell production right in your bone marrow. So here's the takeaway. A patient in chronic renal failure isn't just dealing with fluid overload. They are going to become profoundly anemic because they literally lack that erythropoietin. It is a classic test question, I promise you.
Moving to our second NCLEX point, we have to talk about gerontology and age-related changes. Remember that as our patients age, they go through some very specific physiologic shifts. Their renal blood flow drops, which means they lose some ability to concentrate or dilute urine when their bodies are stressed. Their physical bladder capacity also shrinks, and that leads to nocturia, waking up multiple times at night to void. But hey, listen very closely to this distinction. While incontinence is definitely common in older adults, it is absolutely not a normal consequence of aging. Never, ever assume incontinence is just a normal part of getting older.
Okay, Section 2, Assessing Urologic System Health. Let's see how all this foundational knowledge translates to the bedside when you're actually assessing a patient with urinary issues.
Hitting our third critical NCLEX point, you literally have to have these exact terms memorized to decode your test questions accurately. Dysuria, that's painful or difficult urination. Hematuria is blood in the urine. But I really want you to laser focus on anuria, which is the total absence of urine, and oliguria, which is a severely low urine output. If you ever see a patient producing less than 30 milliliters per hour, alarm bells should be ringing. That is a massive red flag for renal failure or poor kidney perfusion, and you have got to act on it immediately.
On to Section 3, Diagnostic and Lab Tests. Once we've assessed the symptoms and jotted down the right terminology, we have to identify the exact problem using these tests.
So this brings us to point number 4. This is absolutely crucial for your exam. You have to know the difference between these two vital labs. Blood urea nitrogen, or BUN, is a good general indicator of the kidney's ability to excrete urea. But honestly, BUN can be so easily skewed. Dehydration, eating a super high-protein diet, or even having a GI bleed will just cause BUN to spike. On the flip side, we have serum creatinine. Now, creatinine is a waste product of skeletal muscle breakdown, and unlike BUN, it doesn't care about your diet or your hydration status. Because of that, serum creatinine is the undisputed gold standard. It is the absolute best measurement of actual kidney function.
Now, for urinalysis, you should always keep these normal baseline values in the back of your mind. You're looking for amber yellow, clear urine. The specific gravity, which measures how concentrated the urine is, should sit right in that sweet spot, between 1.005 and 1.030. Any variations here are telling you a story. So for example, If that specific gravity creeps up above 1.030, it immediately tells you the urine is highly concentrated, which points straight to dehydration or diabetes mellitus. Likewise, if you're seeing positive glucose or ketones, you're not just looking at a kidney issue, you're likely looking at poorly controlled diabetes or even starvation.
But sometimes labs just aren't enough, and we need to get a direct visual. When a provider looks inside the bladder during an invasive procedure, like a cystoscopy, they use a lighted instrument threaded right through the urethra. You can see the trigone here, the detrusor muscle, and the ureteral orifices. This is exactly the area they're scoping out for any abnormalities, blockages, or tumors.
And because a cystoscopy is an invasive procedure messing with some very delicate tissue, we arrive at NCLEX point number 5. You've got to drill this one into your brain. After a cystoscopy, seeing pink-tinged urine? That's totally expected. It's a normal finding for a day or two. But if your patient suddenly starts passing bright red blood or blood clots in their urine, that is a full-blown emergency. It means there's active hemorrhage and you have to notify the provider right away. No waiting around.
Section 4. Key nursing interventions. This right here is where the rubber meets the road. It's where you, the nurse, are going to make the biggest impact on patient safety at the bedside.
Point number 6 highlights your direct responsibility in all of this. Catheterization should only happen when it is absolutely 100% necessary, like if you need a strict output measurement or if the patient has severe retention. And when it is necessary, strict aseptic technique is completely non-negotiable. Why? Simply because introducing a catheter is the #1 primary cause of healthcare-associated infections, or HAIs.
NCLEX point number 7 is just this one specific number, 50. Less than 50 milliliters is considered a completely normal post-void residual volume. To figure out if a patient is emptying their bladder all the way, we check their residual urine right after they void, usually by using a quick, non-invasive bladder ultrasound scanner. If that number pops up substantially higher than 50, you're looking at urinary retention, and that's an issue you'll need to address.
For point number 8, we're looking at specialized tubes, specifically ureteral and nephrostomy tubes. Now, a nephrostomy tube is placed through a flank incision directly into the kidney pelvis, usually to bypass some kind of obstruction. The absolute, undeniable golden rule here is that it must drain freely and continuously at all times. Never, ever clamp or kink this tubing. If that urine backs up, the pressure's going to build up directly inside the kidney and it will cause severe, irreversible tissue damage. Just don't do it.
Which leads us perfectly into point number 9, and this is a concept that trips up nursing students on exams all the time. The capacity of the human renal pelvis is incredibly small. We're talking only 3 to 5 milliliters total. So if a provider actually orders you to irrigate a ureteral or nephrostomy tube to clear out a blockage, you have to proceed with extreme caution. You irrigate super slowly, and you never, ever instill more than 5 milliliters of lukewarm, sterile normal saline. Pushing anything more than that will cause immediate trauma.
Finally, we've made it to Section 5, Essential Urologic Medications. Let's wrap up this whole clinical picture by looking at how we actually manage these conditions pharmacologically.
You will absolutely need to know how to differentiate these drug classes. On the left, we've got our diuretics, like the loop diuretic furosemide. These guys force fluid and sodium right out of the body, which dramatically increases urine output. But because it's not potassium sparing, you have to be on high alert for hypokalemia. On the right side, we have urinary antispasmodics, like oxybutynin. We use these to calm down an overactive neurogenic bladder, but keep their anticholinergic effects in mind. While they do a great job stopping the spasms, they can inadvertently cause urinary retention, dry mouth, and blurry vision.
Our 10th and final NCLEX key point focuses on the safety profiles of 2 really high-risk urologic medication classes. First up, if your patient is taking a sulfonamide antibiotic for a UTI, you've got to encourage a massive fluid intake. We're talking at least 1,500 milliliters daily just to prevent crystals from forming in their urine. You also need to teach them to avoid direct sunlight because of photosensitivity. Second, patients taking immunosuppressants like cyclosporin, which you'll see a lot after kidney transplants, have severely reduced resistance. You literally have to watch them like a hawk for even the most subtle, tiny signs of infection. To wrap up this explainer, I want to leave you with a next-generation NCLEX scenario that's directly based on what we've literally just talked about. Imagine this. Your 50-year-old post-cystoscopy patient just voided 150 milliliters of bright red blood with clots. Based on our 10 key points today, are you simply documenting this as a normal finding and going about your day, or are you rushing to escalate this to the provider immediately?
If you aren't 100% sure of your clinical judgment on this one, you might want to rewind and review key point number 5. Master these 10 concepts, and you are going to be well on your way to absolutely conquering the urologic system on your exams. So what's your priority action going to be?